Thank you, and thanks everyone for joining us this afternoon for a portion of your last day here at Hess. I'm excited to talk about this topic today because I think it's not only timely, this is something we're actively working on right now. We've spent years trying to figure out how better to engage our physicians in our improvement work, but I also think it's pertinent. I think it's something that any organization who that wishes to truly transform or stand out in the next 5 to 10 years will need the capability to engage their clinicians, their physicians in a different way. The slide is correct, the introduction as well. I am a physician, Jack is a lawyer. There's probably some joke that starts out a doctor and a lawyer walk into a healthcare analytics conference. We don't have that one in our repertoire yet, so if you have a good one, do send it our way.
Innovative.
Innovative, yeah. This is our plan for the next 30 minutes or so. We'll spend the majority of our time really talking about the three ways, the three programs, if you will, that we've developed over the past 12 to 18 months, focusing on engaging physicians at different levels and in different ways with improvement work inside our organization. We'll tell you a little bit about how they're working, so some early results. Some of these programs have really only been active and deployed for 4 or 5 months, so there's some early results, some hot off the press even, we might talk about. I'm going to make our Health Catalyst team very nervous here for a second and go off script on the first slide. So how many in the room, in a very low-tech poll, raising your hand is the solution here, it's not a poll question, how many in the audience have ever had the pleasure of trying to tell a physician they need to do something differently? Okay. Wow. Appears we are among friends. Not an easy thing to do.
I do it frequently.
Yes, almost every day.
Yeah.
Not an easy thing to do, and you know, I can make light of that subject because I'm one of the tribe, but the reality is it's something that we do need to figure out and be very good at as organizations. So
our learning objectives, I guess I'll start with, we sort of came to this work, not scientifically, but it was through trial and error. We've spent a lot of time, and we'll get into a little bit to the history of our organization, but our organization was sort of very decentralized. That was the state of our organization historically up until about January 1st of 2016. At that point in time, we brought it together. We tried, it was probably early 2016, to work in meaningful performance improvement measures into our relationship with our physicians. And we tried, this went over the course of, say, 2 to 3 years, so it was a very long process. Ultimately, we concluded without being able to bake those into our relationship with the physicians. And ultimately, I think what we concluded was that they didn't trust the measures that we were trying to impose on them, right? So they hadn't seen the data, they hadn't validated the data. We didn't have enough of the data to actually be able to get them to agree to develop consensus in order to be able to impose that on them. And I think that's another distinction, a key distinction, I think, in terms of what you'll see here is we don't want to create, I think our model is not to create a set of duties for physicians to add essentially to what physicians already do. What we're trying to do is to create a true partnership. So we're trying to create that pull really from the physicians to actually partner with us along that performance improvement spectrum. So some of the learning objectives, verbalize several ways data can be used to engage and align with physicians in leading improvement work, identify the levels of physician leadership in our organization that can be engaged to drive improvement. We use here leadership loosely, right? So we have the formal leadership that already exists and is in place, but really this work is really to sort of span and to develop additional leadership throughout the sort of spectrum of our organization. Become familiar with the types of data and information of most interest to physician leaders, and I think as well how to present that to them in a way that they trust. And then develop at least one mechanism that can be used to better engage physicians in improvement work.
Okay, poll question number 1. On a scale of 1 to 5, how would you rate your organization's effectiveness in engaging physicians in improvement work? You can vote 1, not at all effective, all the way down to 5, extremely effective. Go ahead and vote on your app if you haven't done so already, and let's go ahead and start to look at the results coming in. So So it looks like the majority of the folks in the room are going with 4 moderately effective. Almost half. But now we're starting to get some people saying somewhat effective. What are your thoughts on that?
So I think this is, I suppose, not all that surprising, right? So I would guess that there are a lot of those of you in the room with us who have started the process, right, of being able to start to engage physicians, have started work in terms of working with them to generate improvement. But my guess as well is that maybe you don't have that consistently applied. You don't have it spread. Maybe it's confined to one or more particular physician leaders, and so it hasn't sort of emanated down, right, to the rest of your staff. And my guess, too, is that currently it's probably very transactional in nature, right? I think that's what we find with physicians, right, is that they are one of the few sort of employment categories or personnel categories in hospital and other provider-type organizations, all of whom have contracts, right? And they're highly paid. And so the relationship with physicians tends to be very transactional. So my guess is there's an aspect of that that is incorporated into whatever the relationship is, and thus kind of creates the relationship from a transactional perspective. So a little bit about us. As I noted, we large hospital, tertiary, quaternary acute care hospital, along with some behavioral health hospital services based in Kansas City, Kansas. We have some other outlying hospitals, community hospitals in the state of Kansas. But the hub is in Kansas City, Kansas. And so you can see from the statistics on the screen, large, we had a census today of this morning, I believe, of 807. So very active, a disproportionate share hospital. So we have, the sort of additional challenge of being able to, or having to deal with, low income, uninsured, a lot of Medicaid, a lot of Medicare. Our physician group, the University of Kansas Physicians, is, I think right now, about 1,000 physicians, probably a little bit over. As I had noted up until 2016, that group of physicians was sort of scattered amongst 18 different nonprofit entities, essentially what we viewed as foundations that corresponded with clinical departments, right? So very scattered, very sort of decentralized, made it virtually impossible to have any sort of alignment in terms of being able to engage in improvement work. 2016, we brought them under this new multi-specialty faculty practice plan or group called the University of Kansas Physicians. Really what we did then and what we know now is that we really just set the foundation for being able to sort of focus and generate the type of relationship and interaction that would ultimately result in the type of improvement and the type of synergy and interaction that we'll need in order to be able to respond and improve as necessary, I guess, to deal with what we're all dealing with within the healthcare industry.
So I'll tell you a little bit about the teams that we use to support this work. These teams that I'm going to outline now do have a responsibility across the entire system, so not just at the hospital that Jack just described. But I will make a distinction there for just a second. The work that we're talking about with our physicians is primarily, almost exclusively, with the 1,000 physicians that operate in Kansas City, not at our hospitals across the other hospitals across the state. So these teams, under the umbrella that we call performance improvement, really cover the gamut, the entire continuum of performance improvement activities, but they also support improvement across the entire continuum of our business. Everything from how we manage and measure and assess mergers and acquisitions, or potential mergers and acquisitions, all the way through how we analyze our consolidated financial statements, and every clinical and business opportunity in between. Our Business Intelligence Solutions team is our kind of expert team on sharing information with the organization. So how we answer one-off questions, how we develop tools to share information easily and openly across the organization. Our Applied Analytics team is really the muscle for advanced analytics, predictive modeling, prescriptive and predictive, and anything kind of special that we're working on. And then our lean promotion office is the part of our team that develops, supports, and deploys our improvement system across the organization. These three teams work in conjunction to address this problem. I have to thank, or maybe blame, Dale for sharing this with us several years ago. We just shared a hand-drawn version of this that introduced the problem, and the concept is pretty simple. The value of the data that we collect in healthcare is actually determined by how quickly we can analyze it, share it with the right people, and use it to improve. So the closer we can do those things to the business or clinical event occurring, the more value there is in the data and the work that these teams do. So those three teams work in different ways and at different times to address components of that curve. Some of them overlap, but all of them are focused on compressing that curve up and to the left, generating more value from these things that we have been working on and building from an analytics and a data perspective for many years. That problem gets more complicated, though, when we engage physicians or involve physicians in the conversation. I hear these comments or concerns from different people in our organization in different ways almost every day. And I believe that all of them are true in certain circumstances. We all know or have experienced, if you're a practicing physician, the burden, the challenges that our clinicians face today. We know that there's ballooning student debt. We know that there's an ever-increasing administrative burden from health plans, for prior authorizations, for prescription refills, you name it. And we know that we continue to build this thing called an EMR, which has the promise of helping us take care of patients, but really has done everything but, up until this point at least, everything but make it easier to do so as a physician. And anything that we add on top of that, even if it is aligned with that physician's purpose or interest, could be that proverbial straw that breaks the camel's back. We're talking about a group of professionals who are highly educated, highly paid, and who as a profession have been used to being the primary decision maker in their industry and suddenly find themselves not in that situation anymore. And then we ask questions like, why are they so burned out? Why are they so disengaged? Why is there this concept of moral injury that continues to rear its head? And I'm proud to say that we took into account all of those things as we thought about how we would want to engage our physicians in improvement work in a way that these tools, these programs, these projects were actually tools for engagement and alignment that improved those things, not things that we had to manage. So I have a lot of favorite Ron Heifetz quotes. Probably my favorite is actually not this one, but goes something like, and I'm paraphrasing here, the largest leadership failure is treating an adaptive problem as if it were a technical one. So if you're at all familiar with this concept, you might remember there are two types of problems that we as organizations face. There are technical problems, and I don't mean technical in the sense of what is the technology solution to employ here. I mean technical in that we know how to solve this problem. We just need to do it. That's a technical problem. And then there's this group of problems called adaptive problems, and they are problems where individuals, groups, or the organization need to learn how to do something totally new. We could have approached this question of how do we engage our physicians as a whole more in improvement, because it's imperative to our organization. We could have approached that question as if it were a technical problem. Many of us in the room, I included, have been involved in projects where the entire plan, whether it was identified by a consultant or an administrator, was just go tell the doctors to do X. That was not our approach at all here. We did not redo something that we'd done in the past. We did not apply a technical solution to a very adaptive problem.
Hard moving here. So I think this is an accurate reflection of our clinical improvement work as of May of 2017. So you'll note that that's about 16 or 17 months after we integrated with our physician group. I'm just curious, by show of heads, how much does the sort of third row there, the third point, resonate? Do people get the sense that there's an us versus them mentality within your organization?
I think you're on the wrong slide.
Oh, I'm sorry. There you go. That'll help. So I think what we realized, right, was that that was a huge barrier for us. I think, the legacy medical director program probably wasn't always the right function in which to engage physicians through improvement work. The clinical departments vary in their support for and mechanism of improvement work. That really was a symptom, quite frankly, of the third point here, which is it was us versus them, right? There was a level of distrust that existed between us and our physicians. And frankly, it wasn't enough to build it into the compensation formulas, right? So in my prior life, I went around the country sort of doing large, complicated physician deals, and I can't tell you how much time I spent trying to negotiate quality or value components to physician compensation, right? And I can't tell you how many times after we did it, I thought to myself, I'm not sure that's going to be all that helpful, right? But it made us feel better because we actually had it incorporated as one of their duties, right? And I think actually what we did was we looked at ourselves, and I think our mindset was, right, you're going to have some physicians that continue to be disengaged. And yet we never really tested that, right? We probably thought, there's some people who probably thought that to actually sort of empower some communication or additional communication, additional information to physicians, those physicians would use it and they would be boisterous or sort of otherwise problematic behaviorally, right? But we never really gave them an outlet to be able to use that, to voice their concerns and their ideas constructively in an informed way. And then I think similarly, we probably there was a fear, frankly, that they would take the information and run too far, right? But we never gave them any direction. And so I think what you'll see from some of the initiatives that we've developed, it really is to probably take those assumptions and to really start to test those through practice with our physicians. So I think this is our future state, right? So this is kind of philosophically kind of what our utopia is. But it is, in fact, sort of philosophical, right? We know our physicians will be essential to getting us to where we need to be longer term to be successful, right? To develop the sorts of innovation, the level of improvement that we'll need to continue to be successful. We know that not only must our physicians be engaged, but I think as importantly, they have to be aligned, right? It's not enough for them just to sort of speak up and sort of show some interest. We want them to take ownership. Essentially, we really want them to be our partners, right? And we want that to be spread throughout the organization and not be confined or isolated to just the high-level formal leadership that we have. I think, structurally, we're like, I think, everybody else, right? We don't necessarily know what that's going to look like 5-10 years from now, right? We know that there's a runway that we have in order to get there. I think we see the evolution being from engagement to responsibility, right? So we have physicians that start to develop and take on responsibility for likely particular initiatives or particular projects, and then ultimately to shared accountability, right? Again, that gets back to what are we really trying to develop and collate here, and that is a partnership with our physicians. And I think lastly, one of the things that we believe is essential to that, again, is to have that trust and that transparency, and that's really what's developed through the use of data and information.
Okay, poll question number 2. How frequently does your organization share departmental performance information with clinical departments? Go ahead and get your votes in now. And let's go ahead and start to show what's coming in. Looks like most people are going with monthly. And the second largest group is the ones going with weekly and more frequently.
Yeah, so I'm not really surprised by this, although I am a little bit sure of or surprised by the unsure or not applicable being such a high percentage of the room. And maybe that's a reflection of the audience, or maybe that's a reflection of we're actually really not sure how we do this. And that wouldn't actually be all that surprising either, I suppose. The monthly piece makes sense, right? We generate financials on a monthly basis. We generate volumes on a monthly basis. We share performance on a monthly basis. We focused a lot on getting real-time information as appropriate, where appropriate, in the right tool, using the right avenue to the right person. And so we have some things that are monthly. We have some things that are daily or weekly, even around departmental performance. So let's get now a little bit into how we did all this. So that's a lot of background about where we're at and why this is a problem that's important. But we worked for about 18, maybe 24 months on some of these projects to develop a number of ways to engage physicians, and as we've mentioned several times, at multiple levels in the organization. So our Care Connections program is really the local improvement level. It's where we engage informal or formal leaders in point improvements in their unit, in their clinic, in their disease group, something like that. Then we have what we call value-based performance, and this is divisional or departmental improvement work. This is not point improvements, this is line improvements. This is engaging a whole group of physicians like pulmonary division or the anesthesia department and identifying a project and providing them the data to help them problem solve and generate their potential solutions, and then providing support to test them, but also to do that in a way that we are able to share the gains, the financial gains, with them on a quarterly basis. And then we have our department financial and planning sessions, and these are really strategic. This is how we engage our senior-most physician leaders in the highest level discussions possible about what we need to improve, why we need to improve it, and how we need to improve it, so that we can engage not just an entire division or department, but multiple departments, multiple specialties in improving how we deliver care or the quality of the care we deliver. So our Care Connections program, that point kind of improvement, local level, this is the transformation of a decades-old program we called our Medical Director Program. Many of you probably have something like this, where you have an identified physician leader, you pay in some way for their time to either be a consultant or to lead some sort of improvement work or administrative work. And we knew that we wanted to move far away from that. So there were four key features of a program that we wanted to develop. And the first was that we didn't pay based on time any longer. Our hospital staff who were engaged in improvement work were not paid by the hour differently for improvement work than their primary job. So we wanted to move towards paying for actually getting something done, but not outcomes. We don't want to pay for outcomes. We wanted to pay to try lots of things, to learn, to fail, and to complete a project you planned. Because we wanted, the second bullet here, we wanted to encourage physicians to identify their problems and lots of things to try. Thirdly, we wanted to make sure that we had developed a mechanism to ensure alignment with organizational priorities and to be able to provide ongoing executive support and coaching on things like measures and targets to make sure that the needles we were moving were the ones that were important to our patients and our organization. And finally, and this is an interesting component, we had lots of tension around this, we're an academic medical center. All of our owned physicians in our multi-specialty practice plan are faculty physicians through the university. All of them have a requirement to be academically productive. So we wanted to build into this program a requirement for presentation and an avenue for publication that means that you are sharing what you did and what you learned with those who might benefit at the same time you are building your CV. So those components came together to form what we call our Care Connections program, and there are two arms. At the same time we were trying to identify how we would do those four things, we also knew that we didn't want to stymie the concept of ground-up identification of problems, but we knew that we needed to have some top-down way to control things as well. So two arms of this program. Our Care Advancement program is kind of a request for proposal type program. We say at the beginning of the year as an executive team, we have a list of things that we want physicians and their partners to work on, and we publish that list and we ask people to send us their good ideas and their plans, and they do. We review them and we decide which, in this year's case, almost all actually, which we would decide to resource, both from an analytics and support perspective, but also from a time and financial perspective. And that's what we thought is important. But we also knew that there would be someone at some point in the organization that had an idea that we didn't even know was important. something that would truly transform the way we deliver care, and we wanted to be sure to build a mechanism for that type of idea as well. And so that's our care transformation arm. There's no request for proposal here. We actually just say, if you've got a good idea, tell us about it, and if we agree that it moves the needle somewhere where it's aligned with our organizational goals for the year, we support it. And that makes sure that we've built in this balance between top-down and bottom-up. If we move a little bit to our value-based performance program, remember this is the concept of engaging divisions or departments at that level in improvement work. This is actually not all that different from the Health Catalyst flywheel example, if you've seen it. First, we had to build the infrastructure necessary to support this work. And then really it's helping our divisions or departments find improvements, supporting the division or department in identifying their solutions with whatever analytics are necessary and with whatever ongoing measurement is necessary to tell if their interventions are providing the intended benefit. And then really to get out of the way and let them do their thing and jump in only if there are barriers that need removed. And then on a frequent basis, provide evaluation of what that improvement work and the movement of whatever the measure is means. And share that value, both the monetary value in the sense of gain sharing with the department, but also share that value and improvement with the organization.
Is that my slide? Use one of my slides. I'll actually flip back because I was prepared to speak, and you guys are no lawyers, right? You can't take my my time slot. But one other thing to note here, right, is so again, kind of harping back to some of our kind of key principles, right? So you have within the value-based performance, right, where this ultimately ends up is, so we have physicians find initiatives that we validate with them, then work with them to implement. We implement them, share part of that value, but these are stretch goals, right? So they only last for a year, and there's acknowledgement and agreement that after that year they become standard of care, right? So if you think about, again, going back to how do you actually implement accountability and responsibility with physicians, it often emanates through employment agreements and duties. This is sort of a way in which we're sort of evolving and developing the duties that they'll have to adhere to, but they're actually the ones who are developing them, right? So we think that'll be more sustainable. The departmental finance and planning session, so this is the aspect really that is non-comp related, right? But so we start with, and I think the magic probably here is in the way we do it. So have information packets produced. So this gives the system the ability to provide direction for what our departmental leadership is able to consider and come back to us with in terms of ideas and planning. We then have our teams meet with the departmental leadership to go over the information packets, right? So we are ensuring that they trust the data, that they trust the information, that they're comfortable with it, and that they're prepared to ultimately meet with a large team of our senior leadership. So actually not just senior leadership, right? It's senior leadership plus some additional leadership. We have all relevant stakeholders there. And the key here really is that our departmental leaders lead that meeting, right? So they lead the meeting based on information that we have sort of confined and set the parameters in, right? So we're directing the message, but it's up to them to actually convey, to develop the ultimate message. And then finally, the annual improvement plan is developed, and that's an aligned plan, right? So again, they lead the meeting, we have discussion, and then we collectively prioritize the plan for the upcoming year. And this just kind of illustrates, I suppose, a component of that information packet, right? And so you'll note that none of it is pejorative or in the nature of imposing a punishment or any sort of negative connotation, right? So where it says red, we identify it as an improvement opportunity. So it's intended to be very positive. And frankly, it's those items that are red that we really want their attention on. This goes over some of the additional aspects of what was included. So we have provider productivity, patient satisfaction, which is of course very important to us. Growth and access in particular has become very important to us. And then ultimately market analysis, right? So that they're informed and can provide input ultimately into how the market's changing. The one thing that we haven't yet incorporated into this sort of initiative are specialty-specific quality measures. And I should say, just one other really important note, I think, is when we put these together, right, we have 22 departments, is that right? Mm-hmm. But within those 22 departments, right, we span virtually every single subspecialty. So we have over 125 subspecialties that are ultimately included. Within each department, any subspecialties that fall under that umbrella, we actually deal with separately, right? Because they're all sort of distinct enough to potentially have criteria or factors or issues that are unique to those subspecialties. And quite frankly, that's how we want our departments to start to look at how they operate and conduct business.
So it's probably apparent by now that I like this Heifetz thing about adaptive leadership. But I think this concept is really important here as we talk about what we developed and what we did over the last year as we move into results. So the concept here is that there's a productive range of disequilibrium or productive range of tension. That if the temperature is too low, if you will, people aren't going to do the things you want or need them to do, or they're not going to change. And if the temperature is too high, they're not going to act either. That you have to keep them in this certain range of tension. And we've approached this entire project that way. We didn't want to create a situation where the temperature was so high that we were risking an explosion. We're planning for the future, looking out towards what does compensation for our physicians look like in a way where we want them engaged in improvement work as one of their primary responsibilities. And so we've been very careful this entire time to be good at taking the temperature. And so here's what this has resulted in. At a high level, Care Connections has 37 active individual projects this year. And 17 of the 21, now 22, and we just had an additional department this year. So 17 of 22 departments are represented in that work. A good breadth and cross-section of the organization. I wish I could show you results from those projects. Their first quarter results are due here in a week or two. And I fully expect that most, if not all of them, will show benefit in one way or another in the things they've been doing in the first 3 months of our fiscal year. Our value-based performance program project started kicking off in March. And 80% of the projects showed measurable financial benefit in the first month. I've never seen a program in our organization where we see that sort of immediate benefit, and it has continued month after month since then. We'll show you some examples here in just a second. And then at the highest level, the strategic planning work, 21 of 21 departments that went through that process have annual improvement and growth plans in place. And through that process, we identified 100 other organizational level projects that we needed to tackle this year or next that we were not aware of up until this point. So to move to some specific examples of how our analytics teams, our data teams support this work. This is an example where our pulmonary team came to us, so our pulmonary division inside the Department of Medicine came and said, we think we've not been engaged in the right ways in managing COPD patients who hit our hospital, and we think we can help. They had a whole series of plans. And this was complicated. This was complicated because our analytics teams actually had to identify the direct cost of a COPD admission to determine the value that we would share with the pulmonary division, because this is actually probably a loss in revenue in our market at this point in time. Nearly all of our commercial payers still pay for readmissions. And there's a Medicare penalty, of course, but it's harder to understand what the value of a single readmission is in that world. And so we had to settle on a value that might actually mean lower revenue for us in the short term, but sets us up to be well prepared in the long run. And that gets down to activity-based costing at the dose level. All of these projects will actually, down to the minute for activity or down to the dose for a pharmaceutical, or the individual line item level for supplies. Another example, actually I should really quick say, that decrease in readmissions is real, although the June number, this was submitted the end of July. So not all of the June admissions or readmissions were coded yet, but as of the August measures, which came in on while I was on the plane out here this week, that readmission rate was 4%. So we'd gone from a peak of 28 down to 4 in half a year. Pretty significant improvement. August looks to be good as well. Our anesthesiology department said, we believe we can be better engaged and can help support cost reduction in the perioperative space. We know that Tylenol, as a form of multimodal analgesia for perioperative patients, is of benefit, and we know there are two forms. There's an oral form that's been around forever and costs $1 and change, and there's a brand new, highly marketed by the drug reps IV form that costs $130 a dose, and they're equally effective. And right now, 98%, as a baseline, 98% of our patients who got Tylenol as a perioperative adjunct were receiving the IV dose, 98%. So our anesthesia department said, we can help there. And you can see here the change, right? From March, when they started their project, so a baseline of 2% getting the oral, that's what we see here. The substitute is the oral dose. 2% of the total patients receiving Tylenol in the perioperative space were getting the oral dose at baseline. By the end of April, we were at 3%, then 5%, then 7%, July was 12%, August was 20%. Immediate and measurable improvement that results in financial benefit to the organization and the department. And then finally, a third example of what this looks like. Our medical ICU, our critical care teams in our Department of Medicine came and said, we think that if you tell us exactly what the cost of a course, a comparable course of 2 different antibiotics is, we can choose an equally efficacious antibiotic and reduce the spend on antibiotics per patient per month. And they did. So at a baseline of around $170, $175 average per patient per admission for a direct cost of antibiotics, down to $100, and that has now been sustained for 3 months in a row. July, August, and 2 months in a row. June, July, and August, 3 months.
He does a much better job than I do explaining those slides. So I think the sort of last sort of anecdote here is this is actually one page's worth of the feedback that we got from our Department of Orthopedic Surgery, right? So all of this is feedback from our department that sort of served as the prelude and the agenda for those planning meetings that we discussed earlier. And so we'll end with this, right? So we know that engaging physicians is essential. It's worth the investment of time. I think the last point here, though, is the most important, I think, for us. It was kind of it has affirmed sort of what we expected, which is that it's aligned and not dictated improvement efforts that generate really meaningful, constructive, and successful physician engagement.
All right.
No, do I go back?
All right. All right. All right. There we go. Okay, thank you so much for that excellent presentation, Dr. Wild and Jack. So we're going to move on to the Q&A section. And we did have one joke for you that popped to the top of what you could use.
Nice.
We did have a couple, but there was one that popped to the top, and I'll just read that one really quick. A doctor and a lawyer walked into an analytics conference, and they were outliers.
This is true.
All right. Let me move this way so I don't stand right in front of you guys. So based on votes, the first question is, how do you get physicians to opt into risk sharing in an era of value-based care?
I'll start and then let the legal mind jump in. So one of the things that's important in this process is that, and I didn't touch on it, I don't think either of us did, the gain sharing out of these value-based performance projects is both a significant percentage of the savings, but it's also only upside risk. So the way that we start down that path is by offering benefit with no downside risk. There's nothing at stake if those measures don't improve, other than you're not likely to get support for an idea that's similar to that in the future.
Yeah. So I think that, I mean, as David noted, so we're really trying to step into this. We would have preferred to impose some degree of risk sharing on our physicians initially, but we got too much pushback. And again, most of that pushback was, I think, distrust of the information that we were presenting. I think distrust of what they actually contribute to our operational areas that were under consideration to sort of fall under a risk-sharing model. And so longer term, though, I think, again, this is really as much intended to generate familiarity with or by our physicians in the information, and so that they understand better, right, what they actually contribute, and sort of degrees of kind of control and variability, so that they better understand maybe how their performance ultimately it fluctuates or can be impacted in particular areas. And so I think we know ultimately that where we want to get to is actual sort of risk sharing. We didn't feel like we could do it, though, without developing the sort of trust and the familiarity by them and us. I think it would be very hard to do unless it was just absolutely necessary, right? And I think sort of the crux of that question is if it's not absolutely necessary, right? If the world doesn't change and that's how we're reimbursed. I mean, obviously, if that happens, I think market changes. And I think probably there's an acceptance by physicians that they'll have to change. I think we want to be in front of that curve, right? So again, sort of dipping our toe in the water here initially, where it is cost neutral for us, right? So there has to be actual cost savings, and then that is split with our physicians. But on top of that, there are gating measures relating to quality and service, access, charge documentation, and charge timeliness. So all of those things I think we expect will be part of future reimbursement models. Those are embedded into and consistently embedded into our value-based performance compensation program.
And the only thing I'll add to that is those are all very key examples of how we're in this with the long view in mind. We do have a target date, determined by our board for moving a larger portion of our physician compensation away from RVU production and to pay for value in some way, shape, or form. That date is not right now. But because we know when that is and we're working towards that over the long run, we're able to start now, back to that concept of productive range of tension, we're able to start introducing that long before we're under the gun. And so it's not this feeling of imposing anything new, but instead engaging and allowing those who are ready and want to be involved in that gain sharing and that risk sharing to be the first in line.
Yeah. And actually, just to one more point, what we've heard, if not uniformly, at least generally, is that our physicians, after being introduced to really all of these initiatives, have really kind of flipped. I think they all accept the fact that some degree of risk sharing is coming, and frankly, they're all in favor of it.
So how do you ensure that physicians are not inundated with too many performance improvement initiatives? In other words, how do you prioritize improvement initiatives?
If anyone has a magic, all-encompassing answer to that question, please let us know. I think I can be very honest. We struggle with this. We're an organization who likes to do a lot of things, the shotgun approach to many problems. And I think we have to be very thoughtful about how we approach things that we are asking physicians to do. So the first layer, or first test maybe, if you will, that we have to pass is this something that our physicians must be engaged in? Is it something that only our physicians can change? Or are we asking them to do something that we maybe need to be involved in first? And use that as the litmus test. Is this something we must do or must not? And then start to sequence them. And so I'm not sure that it's prioritization in our world right now as much as it needs to be, but it's a lot of sequencing. What has to come first and what must be done right now?
Yeah, I think we knew that there would be a lot of resources that would be necessary to do this effectively. The reality is we need more resources. We talk all the time about needing to add, and with Chris Harper, about needing to add members to our respective teams to be able to support this work. I think that's probably coming. I think, as time goes on and we can continue to see the utility of this work, I think certainly that becomes more justifiable for the organization. But I think right now there is recognition, right, that it's going to be harder, right? It's just a bigger lift initially than what it will be over time, right? So I think it's making sure that our leadership also understands that. I think it's, the more that we do, obviously the better, but we're really laying the foundation and the framework, I think, for kind of a broader scale approach, quite frankly, to how we look at performance improvement and how we sort of build quality and efficiency and all those other non-productivity metrics into our physicians' work.
And maybe the only other thing I would say to that is, I think we touched on it in a couple of ways, but almost all of these improvement ideas for these programs, the physicians that are participating are choosing to. So there's not a lot of forcing them to have this next new measure. If they're not wanting or interested to participate, they don't have to at this point. And so I think that's helping us as well.
Well, and I would say also, just one last point. To me, I think to both of us, right, and I think to Chris and our senior leadership, if you sort of categorize the buckets of work that we have as a performance improvement department, those can be inpatient hospital and ambulatory, and there's a host, strategic and finance. This work with the physicians is up there. I mean, if it's not number one, it's top two. And so we prioritize the work relative to our physicians generally, right? As amongst the initiatives here, I think that's actually, frankly, more of the struggle because we actually are getting a lot of pull. But organizationally, this is really one of our top strategic priorities.
So one of the questions that popped up kind of just about what we were talking about, and in follow-up to that, how much do you think physicians not having strong accountability leads to their lack of engagement?
I think it's big. Physicians are, they run around in white coats and dress differently and wear scrubs and you got to call them doctor.
Yes.
But I absolutely think that it's crucial. Again, I think what we're really trying to do is to create alignment and buy-in, right? And so we think that will lead to accountability. We don't think we'll get to an acceptance of accountability by our physicians merely by dictating or having as part of their employment some duty and within their employment agreement. At the same time, I think we also realize that we're dealing with sort of a historical framework in which our physicians didn't get a lot of information. We had physician leaders that were really leaders in name only. And, we would hear from them when kind of things were burning. And so we're really trying to help them develop to become leaders. We're trying to give them a voice to develop trust, to ensure from their perspective that they have the resources that they need. And the idea really is to frankly create some success here, right? I mean, we want projects that work. We want these initial initiatives to work because then we're generating momentum with the physicians. They get buy-in. Again, we go from engagement to responsibility to accountability. That's kind of how we see the evolution here.
Yeah, I think, everyone would agree, I believe, that in general, doctors are a fairly competitive lot. And so if you give them the information around a measure that they understand and agree with, you're most of the way there. That has been lacking, I think, in a number of ways. And so we're trying to address that, but still trying in some circumstances.
So one more question that's popped to the top is, what is the difference between your analytics team and your process team?
So from my perspective, at least, our process improvement, our lean promotion office was the first team that I was involved with building and leading here on this organization. And that team definitely has some basic analytic skills, right? They can tell you how to interpret a process behavior chart. They understand the measures of central tendency. They're able to do a lot in Excel, but that's not their primary focus. And so I think that's the difference from my perspective is they are focused on what is the system that we build, what are the tools, what's the support that we offer for actually improving performance once we've been given the analytics and the information and the data to support the direction that we need to go.
There's also improvement work that happens outside of that group. So that's a group really that is more of a centralized group that we deploy throughout the organization, and they work with our executive sponsors to engage in process improvement. I would say both groups really, they are complementary to each other, and they're both at this point pretty widely dispersed, but they're not necessarily dependent upon each other.
Okay, we have one more question, and then we will be out of time. So, quickly, were there any physicians successful in gaming the system to be paid for project completion that might be low value or not helpful?
Historically, of course.
Yes.
As we've been working on revamping these projects, none that have become apparent to me. I imagine we will cross that bridge at some point here soon, especially as we get more involvement. I think that part of our focus up front on making sure that these things that they are working on are aligned, and by having a quarterly reporting process for individual projects and for value-based performance, we can see long before we've invested a lot of time and effort and support if it is aligned or someone is gaming the system. But we'll see when we get there.
Well, thank you again, and I'd like to give a round of applause to Dr. Wild and Jack.